Good afternoon, everyone. Thank you for joining Track 1 Care and Support. I am Robert Austria, and I'll be your host for the last breakout session of Track 1 of the Summit, Day 1 of the Summit. As a reminder, this track is being live streamed through the platform Q, and I'd like to welcome our remote attendees. The last breakout session will be presented by Marie Lamont, President and Patient Advocate at Doman Life Science Services, and Susan DeFrancesco, who serves as a Patient Liaison Specialist with Alexion Pharmaceuticals. They will be uncovering the tricks to navigating insurance and resources that patients and caregivers should be taking advantage of. So please join me in welcoming Marie and Susan to share about this.
Excellent. Thank you very much.
You're welcome.
All righty. Thank you, everybody. And I know this is part of the last session of the day, so I'm going to try and keep it lively and not too boring here, because sometimes insurance can be a difficult topic. How we're going to take a look at my particular portion of this, and what's interesting is I've scoped out mine in some tight guardrails, and then Susan's going to dive into some additional pieces. I'm going to talk more about navigating insurance. And when I say that, what I mean is what happens when you, a patient, gets a prescription. What happens through the cycle? What do you need to expect? How do you need to play a role in managing that whole process for yourself? So if you're a patient, it'll give you a perspective. If you're with a patient association, it's going to tell you how you can help advise and guide the patients in your group. And if you're from industry, it's going to be important to listen, because you want to be making sure you've picked partners who can help you do this for the patients that you care for. So navigating insurance portion first, I'll talk a little bit about patient costs, and then briefly about financial assistance. So you receive a script. You're a caregiver or a patient. If it's a rare disease, frequently because of the cost, it's actually not coming to you as a prescription in paper. It's going to go through some sort of specialty pharmacy who's going to be getting that script on your behalf. Sometimes those specialty pharmacies are identified by your payer, your health plan. Sometimes it's by the manufacturer who may have an exclusive pharmacy. Alternately, it can go through a hub, but whatever happens, the first step is that somebody needs to have a conversation with your health plan about your benefits. And so most organizations are going to go and they're going to do a benefits investigation and verification. There's some key components to that, because if your drug, your therapy is not covered by the insurance, you want to know that up front before you receive the drug, before you incur costs, so that you can try and do something about it. So they ask the questions: does your plan cover the therapy? And if they do, is there medical criteria? Do you know what the criteria is? And do you or your family member, if you're a caregiver, meet that criteria? So all organizations should be going through and doing this first. Now, you can go out publicly and find what the criteria is, but not all plans are going to give you necessarily all the details all the time. This is the first step that occurs. Then, the next question is there a prior authorization needed? Now, I don't know how many folks are familiar on the stream or in the room with a prior authorization, so let me talk briefly about what it is, the what, the why, and the how. There's a lot of terms that are used in the industry. Sometimes it's called a prior auth or a PA. But basically, it requires your specialist, your physician, to get approval from your health plan or your health plan's pharmacy benefits manager to get approval for the drug before you take it, because alternately they won't pay for it. It's an important component, and your physician is the one who's responsible for putting together the prior authorization. Now, I'm going to say that, but down in the how, the specialty pharmacy is supposed to facilitate with the physician, and patients can help facilitate it as well. So it's a comprehensive look at carrying this forward. Prior authorizations are used by medical plans and PBMs to keep costs down. And it's one of their ways of making sure they know what's coming through their cycle. What it does do for you as a patient is it slows things down. You've got a rare disease, you have a chronic condition. It could have taken 2 years or 14 or 30 years to get your diagnosis from onset of symptoms. The last thing you're looking for is a larger delay. You want to get your drug, you want to start your therapy, but this is one of the things the insurance companies have put out there in front of you, and I want you to be aware it occurs so that you know it takes time to put together these prior authorizations. It does have a reference number, so once the prior auth is received, that number, when the claim gets put through, it's highly unlikely the insurance company is ever going to reject it after the fact. However, I'm going to tell you that prior auths aren't always required. It would be great if they were, but they're not always. So there's always a question later about whether or not it's going to be covered. So up here, it's a little hard to read with the light font, but let me jump on and say, if the prior auth is not needed, then what occurs is an immediate adjudication through a pharmacy benefits manager happens for your prescription. And what that does is that allows someone to give you your product right away, your therapy or your drug. If it's through a medical plan, however, and not through a pharmacy benefits, you may not know if they're going to actually accept it, even though you meet the criteria. And I draw this out because it's important. A claim could get rejected, and then you go through something called a claim appeal. And that's going to be in partnership with your physician and the pharmacy to do a claim appeal. If the claim doesn't make it through and it's rejected or denied, it becomes your expense. And I really want to make sure people understand that. So if you go to a hospital, they'll make you sign a document that says, if it's not covered by your insurance, you agree to the costs. So it's important to make sure you know what the criteria is, your physician knows, and your specialty pharmacy knows. Because you don't want to end up in a place where all of a sudden someone's burdened with a cost they didn't anticipate. Then, let's assume the prior authorization has been submitted by the pharmacy from your physician. That could either be rejected or denied. And it's important to understand the differences. A denial is very formal. A rejection is not formal. And what a rejection tends to mean is you need to do some additional work. Maybe your health plan requires confirmation of the diagnosis. They require your test results. If you've got certain levels for your disease, they're going to want to know what those levels are. It might include a chart review by the health plan. A specialist evaluation might be needed. And there is something called a cost exceeds override. Some health plans actually have a limit that says you can only have drugs that cost $10,000 or less. A cost exceeds override allows your physician and the pharmacy to go to that health plan and say, this is a very expensive drug. It might be the only drug for my condition. I have a rare disease, a chronic condition, and this is what's needed to help my health outcomes. And that application, if you want to call it that, is a cost exceed override that the insurance company will provide. There's also something called step edit therapy. And I don't know how familiar your folks are with step edit therapy. Basically, it might mean your health plan requires some other treatment first. And it doesn't mean it's the same, it's a competitive treatment to the prescription. They may require other steps to occur first before they're going to reimburse this particular drug. It may mean the first line that the insurance company picked is cheaper. There's a wide variety for that, but step edits can sometimes be required, and the insurance plan will call that out. Alternately, an insurance plan might come right out and do a formal denial when you go for a prior authorization. Effectively, they're saying they won't cover the payment for that drug, which is a very frightening thing. It can occur because step edit therapy is needed. It can occur because the product's not on the formulary. It can occur for a whole bunch of reasons. But there is an alternative, and you can do an appeal. The interesting thing about appeals is you can only do two. You get 2 tries. Now, I'm going to say there's some time windows, and every insurance company is different. Typically, you have a 30-day window to submit an appeal if a prior authorization is denied. Some plans will do 21, some will do longer. On average, let's call it 30. And then they have about 45 days to respond. Now, if you get a rejection and you go through and you provide the additional documents, you're probably going to go back over to that cycle where it goes through your PBM or your health plan. If you go through the denial, you have to decide if you want to do an appeal. And it's important to talk about this appeal because it is the patient's appeal. You decide if you want to proceed. I'm going to say that because sometimes physicians say, oh, it's too much work to do an appeal. It is you, the patient's determination, not your physician. Because if anybody's going to do an appeal, it's going to be under your name for your benefit. So you get to weigh in. If you decide you don't want to do one, that's your call. But it truly is a patient decision here to do an appeal. So you can request it and decide to move forward, and then it's a coordinated effort with the physician, with yourself, with the specialty pharmacy, and with your insurance company. Now, I'm going to say part of this appeal is called a medical necessity appeal. It's different than a claim appeal when you've already submitted a claim. A medical necessity appeal is a legal definition with insurance companies. It is not a medical definition. And what it does is it requires formal documentation from your physician that you have a medical necessity for this drug. What physicians can do instead of a formal document, they can do a peer-to-peer conversation with a medical director from the health plan. A lot of physicians are going to choose it because it's easier than doing a formal document. It will depend on the drug, the physician, and the health plan. There are templates that physicians can find out there online for medical necessity appeal. I discourage it because most health plans take a look at the templates and go, oh, because they're looking for more content. So you can use a template, but just you don't use something that's too cookie cutter. The things that they may ask for is diagnostic evidence, chart details, your history. They're going to ask for a lot more from your physician as you go through the appeals process. But I do think it's a worthwhile endeavor if you're truly believing in the therapy that you want and that you really want to receive. If there's a first appeal that is denied, you have one last chance. And it's going to be important to just figure out why was it denied and how can you overcome it. And it may very well be the treating physician. It could be the insurance company. It could be your support group, your specialty pharmacy. It's hard to know. It's going to be important because if you go through a second appeal, that's your last chance. And we want to make sure people don't ever get to that point if you don't have to. So I do want to jump next, now that I've sort of gone through this cycle, and I believe this is going to be accessible online so that you can all reach it online. I want to talk a little bit about patient costs and financial burden because the world is changing a lot. The average cost of insurance for individuals, especially for family plans, was about 20%. However, out-of-pocket grew 77%, which is outpacing health plans' average payment per enrollee. So it means your costs are growing at a much more rapid rate than your health plans are. And that is occurring because employers are transitioning health plan costs to their employees, and plans are transitioning them to patients. There's a couple of analyses by the Kaiser Family Foundation that shows high deductible health plans are now offered by more companies than offering HMO plans. 16% of companies offer high deductible health plans, and another 41% are actually going to move to that in the next 2 to 4 years. That shows that the costs are being transferred into patients' pockets. Health plan to patients, employers to employees. Now, costs can include co-payments, deductible, out-of-pocket expenses, and an add-up of all of those. So it's important to know, is your health plan having an out-of-pocket and a deductible, or an either-or? The patient portion, if a health plan denies a claim, ends up in your lap. What does that mean? Because it's rare, most of the costs of therapy are incredibly high. And that means that your costs start to build up and it becomes a burdensome cost. And I mention this because there are alternatives out there to assist you, and not every patient group and patient family is taking advantage of financial assistance. And it sounds silly. A lot of people say, I don't need it, I'm good. But if you're building up a debt burden that you don't have to, you shouldn't have to. So there's 3 different types of programs I'm going to talk really briefly about because Susan's going to dig in a little bit more. There are branded programs. And when I say branded, that really means manufacturers The industry is providing programs that have their name and their drug's name. They offer copay assistance and patient assistance programs. Now, the challenge is those are unavailable for government program patients, especially Med Part D. So there's a limitation. And the worry is it creates a have and have not group within patients, and that's never a good thing. There are charitable organizations that offer patient assistance programs. Some of them are disease specific, some of them are broad-based support. Those are available to everybody. They're not just limited to one group. The largest challenge is funding, because frequently it can be a first come, first served basis, and it's only available until funding runs out and then is replenished by anybody who's donating into the program. The same thing exists for alternate funding sources with state and federal programs. They're available to everybody, but it's frequently first come, first serve. So it's important to know that these options exist. And I mention this because there are groups of patients, whether it's a generation or it's a disease or it's even socioeconomic, that people don't take advantage of financial assistance. And that means their debt burden is getting bigger when it doesn't have to. There are folks who are fearful of providing brief financials so that the patient assistance programs can figure out if you qualify. I think there's a fear of having financials out in the public domain. However, there is and are laws that protect your financial information. These organizations only need it so that they can review and approve you for the program, or tell you that you don't qualify. So I sit here saying, I see not enough patients taking advantage of the programs, and I really want to encourage you as a patient, as a caregiver, as a patient association, or industry, encourage patients to take advantage of these programs. They're there for you. You need to use them because you can keep your debt burden down. So that's it for me. I hope I didn't chat too long, and I think we're going to go right on to Susan.
Do I press it on here? Okay, so I am too short for a daze. Okay. I'm Italian. I need to be moving. My name is Sue DeFrancesco. I am a nurse case manager. I've been a nurse case manager for 30 years. Hard to believe. I've been out of nursing school for 40 years this year, which is really hard to believe, but I did graduate when I was 4. So I was one of those precocious nurses. So my presentation is on tips and tools in navigating healthcare. Because I work for a pharmaceutical company in my part-time day job, the lawyer who I work with suggested that I say this, and I'm going to very firmly say that this is all me. This is not representing the views, guidance, or recommendations of Alexion Pharmaceuticals. It is also not legal advice. Trust my face. These are just practical tips on navigating the healthcare insurance system in the United States. My first slide is a very technical slide, but I felt it really reflected most of my experience every day. Spending my day looking for insurance is a great use of my time, said no one ever. So I had 3 or 4 incarnations of this little talk until somebody told me, first I thought, ooh, 45 minutes, I could get a lot done. And then they said, well, yeah, your part's 15. So I'm going to just say that looking at insurance is, navigating insurance, you're not in a cruise ship. It kind of feels more like you're going down the rapids in a rubber boat with no paddle, and there's nobody else in there with you. You kind of look like this. I'm the one in the front in the middle. However, the thing about insurance and working to establish yourself with insurance when you are dealing in a situation of rare is I just want to give you my 2-second talk. All of us are born advocating for themselves, right? When you come out, what is the first thing you do? You cry, you scream, right? And you learn when you're a baby, you cry when you're hungry, you cry when you're wet, you cry when you're sad. You spend your babyhood advocating. Then you get older and you learn how to talk so you don't scream as much. When you are working in a situation where you are working with rare diseases, now is the time to remember that part, except for the screaming part, but the advocating part. You all have that within yourselves, every single one of you. I need to tell you that when I went to college, I flunked public speaking because I took one class, stood up and tried to describe how to make a salad, and I ran out and I cried and I never went back. So here I am, right? You can do the things that you are afraid of doing. I don't want you to be afraid of insurance. It's just like mathematics, but not the new core stuff. Okay, so I'm going to give you the basics on these slides, but to go through them all very deeply would take too long. So you can actually take them later on and you can get them offline. There's two different types of insurance, basically, your government insurance plans, your Medicare and your Medicaid. You also can get managed Medicare and Medicaid depending on your state, particularly with the Medicaid. A lot of states mandate now that you have managed Medicaid plans. Then you have your commercial and private insurances, the employer-funded programs, the federal exchange plans, which some people think is a special insurance plan. It's really not. They're actually the commercial plans that anybody who works for an employer can get. They're the same thing. They're Aetna, they're Cigna, they're Blue Cross Blue Shield. They're all the same thing. It's just basically under the umbrella of the Obamacare or the health exchange programs. Some people can buy insurance privately, not me, but some people can. And then there's COBRA. COBRA is also another commercial plan. When you lose your job, you have the ability to get insurance to continue if you pay for it yourself. This is just a very quick slide. If somebody's interested in looking at the healthcare marketplace, you want to go to healthcare.gov. You enter in your zip code, and you're going to send you to your state's exchange. Some states run the program themselves, and some of them give it up to the federal government. There are navigators who you call, and they can help you choose a plan. But one of my tips, the little red clever tip thing, just by applying for one of these plans, if there was ever a question that you maybe, I don't know if I qualify for Medicaid, if you answer a few of their questions up front, they'll tell you. They won't let you go any further. They'll say, you need to think about Medicaid in your state. And once you get a denial for Medicaid, then they'll let you go through the exchanges. But if they think that you can get Medicaid based on the questions you answer, they won't let you enroll. So that's kind of a cool tip. Next, I want you to really come up with a plan. Like we heard first thing in the very first session this morning, we were talking about you must have a plan. When you're thinking about getting insurance, you need to think about who you're insuring. Is it just you? Is it your whole family? How do you use it? What worked for you and what didn't? Sit down and take your steno pad and write down who you're getting insurance for, and write down how you use it. That's so important. If you have a rare disease and you go to the doctor every 2 weeks, then you're going to have to factor in that year every 2 weeks you have a copay for the doctor's office. If you have an infusion that you're going to go for every month and you have a copay for that, figure that in. It's really, honestly, it's tedious, but it's just math. Now, this is a really cool tip that I learned just from working with what I do right now. When you have your choices in front of you, make an appointment with the billing person in your doctor's office or the office manager and sit down with him or her for 5 minutes and say, I have a choice of these 5 plans. First of all, do you participate in them all? Don't be surprised at the end. And when you show them the plans, show them the specific plan you're being offered. Not just Blue Cross Blue Shield, but Blue Cross Blue Shield POS 2 something. You know how they have all big fancy names? Give them those names. I have doctors that of patients that I've worked with who participate in the PPOs but not the HMOs. But you want to be very specific because the people in those doctors' offices, they're the ones who do the billings. They're the ones who know who's really easy to work with and who's a little more challenging. The last thing is, and this is what I say through my whole life, thank them for their time. People in billing are the most underappreciated people in the entire world. Their whole life is numbers. So the other couple things you want to think about when you're looking at insurance, are you interested in an HMO or a PPO? Fancy words, HMO. It's a health maintenance organization. That means you have to have a primary care doctor who decides, you know, if you want to go to a specialist, you can't just decide to go. You have to go to him or her and ask, and you have to work with them to make sure that, you know, they are going to let you do that. Because if you're in an HMO, if your primary doctor says you can't go to a specialist, you can't go to a specialist. But if you have a PPO, preferred provider organization, you can still have a primary doctor, but you can also decide to go to a specialist in the network. When you're looking at insurance and you see, for years, I just looked at the lowest premiums and I thought, I'll take that plan. The thing is, the lowest premiums can also have the highest out-of-pockets. So you want to make sure and do the math on every plan that you're looking at. Now, when they give you the plans and you're sitting there looking at them, they should give you all different kinds of statistics, like your doctor's office is $20, your specialist is $40, your durable medical equipment's paid at 50%. Like, kind of go down the list and just sit there watching NCIS, you know, and then between when, you know, Tony's not in the show anymore, but just kind of figure out exactly how much you think this is going to cost, and you'll be amazed at the differences in how much it's going to cost you over the year. In one of the documents that I'm going to include with my things, I actually have a spreadsheet that I use when I'm comparing health insurance, and I'll make sure that you can get a copy of that. You can just download it. And it's every question I ask when I'm looking at insurance. And I ask a lot of questions. There's a whole section on rare disease. If you have medications or treatments that you have to go through, you can actually call up the member services number on your insurance card, on the back, member services. You can call and talk to them, and you can ask them any question you want. And I would suggest the several questions that are on that form, because they won't volunteer that information unless you ask it. And you'll be amazed at what they can answer for you. I also worked at Aetna as a Medicare case manager for 6 years. That's why I know you can do that. Okay, and this is just kind of what I was saying, your deductibles, your co-insurances. So Marie talked about clinical policies. When you have, and this is just a general standard across the board, a lot of my patients, people I work with, every insurance company has a different approach to certain diseases and certain medical treatments. Some of them will have something they call a clinical policy, meaning that if you have a certain disease and you want to have a certain treatment, they've had their doctors look at all the studies and all the information, and they have had them come up with an opinion. You know how the Supreme Court comes up with an opinion about something? Well, Aetna has come up with an opinion about a lot of things. But what you can do, believe it or not, another little tip from a case manager, if you want to know if they have a policy about your treatment or your disease, or if you've been on treatment for a while and you want to know how they make that decision that they're going to approve it, you can just Google Aetna, or whatever your insurance is, clinical policy, and put the drug name in there, and you'll be amazed, it'll come right up. You can't find it if you go into their site, because I'm not really good at that, but I can just do that. I'm a real good Googler. The policies will differ from one to the other. And I think as a consumer, and who has also in the past had a rare diagnosis myself, and had to advocate for myself with 4 different doctors to finally figure out what was wrong with me. And I did this job at the time, so I understand that frustration. I actually had to go find my clinical policy and take it, put it in front of the doctor in my second to the last appointment. And then my last appointment was the doctor who knew what was going on, and she handled the rest of it. But don't ever be afraid, because you're asking for, make believe it's your, if you're kind of nervous about asking about yourself, make believe you're asking for your child, or your mom, or your dad. Do not be afraid. And so you go through the decision, and you've chosen your insurance, and all your doctors and providers are in the network, which is important. The level at which they will pay your benefits out of network is usually much lower than it is if you're in network. And if a doctor's in network, it doesn't mean that the out-of-network doctor is more special and he's just better. He's just not in the network. Most docs, and docs that you work with, like your primary care and your specialist, they're usually all in the network that you have been working in, because you've been going to them for a while. Or if they're new, you can call the insurance company and you can ask them, is Dr. blah, blah, blah in this network? How about this doctor? You can go down a whole list of 20 or 30 of them if you want, and they will tell you. So patient assistance programs. I'm going to get to the next slide. This is a little bit out of order, I'm sorry. Part of it also being insurance is there's a tool there. There are case managers that work at insurance companies, and I don't know if you ever know this, but they are. They are registered nurses. And they're within your insurance company, they're based on your plan. They are in managed Medicare and some Medicaid programs. They're in the commercial plans. Sometimes they are disease-based. Sometimes they are just cost-based. If you're a family that's using a lot of your benefits, sometimes they'll assign a case manager to you within the insurance company, and she should be reaching out and talking to you. But the other thing is, if you're thinking that you're going to have an issue with the case with your insurance, with your child or you, call the insurance company and ask for a case manager, because you can also do that. And it doesn't cost anything. It's part of the benefit, and it's really nice to have an advocate on the inside, because I was one of those for a lot of people. You also find case managers in the hospital. If you're in the hospital, you have a case manager whether you know it or not, or whether you ever see him or her, but you have one. There's one assigned to every floor in every hospital. Sometimes it's a social worker, sometimes it's a case manager. But if you're looking toward discharge, one of the things about being discharged from a hospital is you have to have a safe discharge. That's their job. That's the term they use. So if you've got a doctor who said, well, you can come in for one day and then you can go home, but you know there's nobody there to take care of you, you have to have a safe discharge. You ask to speak to the case manager there, again, advocating for yourself, because they have to give you a safe discharge. They can't just send you home and if there's nobody there. One of the other tools that's really helpful that I have with my patients, I have them use, is there are patient portals, either the doctor's office. Does anybody use these at all? Yeah, aren't they great? Patient portals, either the doctor's practice will have them if they're kind of based out of a hospital system, or the insurance company. I have actually a portal at my insurance company where I can go in there and look at all my bills. I can see how they were paid. I can see what people charged. They're also free, and they also are like a tool that you can use to kind of keep things in order. Now, these are a couple of other little tools that I use also that are really, really helpful. Keep a copy of your insurance card, your health insurance card, in your wallet. And if you are a mobile person, take a picture of your insurance card on both sides, not just the front. Because on the back, sometimes they have your pharmacy benefits information, they have your member services number, the physician provider number. Make sure you have a copy of those. Just put it in your phone. It's very boring. No one will look at it except you. But it's great to have if you can't find that card. Also, I tell my patients, put the phone number for member services as a contact in your phone under your insurance name, like Cigna. Take that number, put that number in there for member services, because sometimes if you're out and you've got your phone, because I would never be without my phone, but my insurance card, maybe. You want to go ahead and make sure you have that stuff there. You can also put your insurance member number in there too, because sometimes they'll ask you for that. But you can disguise it with O's in the middle of it or something so that nobody else could find it, or put O's in front or O's in back. But that's what we do, I've done. Keeping a binder or a notebook with all your medical information, kind of like a playbook where you can reference important contacts for medical care, medical information, or a health app. I don't know if anybody uses an app here, but they have some great ones. My Medical is one. There's a couple other. So this is another important point. I'm married to an emergency room nurse. We are two old nurses who live together. Rare is really rare until it happens to you, and then it's just your life, right? Yeah, One of the paradigm shifts that you have when you have a rare disease is you go to a doctor, and normally you sit down in front of a doctor and you say, oh gosh, I have diabetes. And he says, well, let me tell you about diabetes. Your pancreas doesn't work. It doesn't make enough insulin. You're going to be on insulin. We're going to try some medication, and you're going to check your sugars every day. He knows everything. But you'll walk into a doctor's office and say, I have atypical hemolytic uremic syndrome. And there's crickets. This is just going to be how it is. This is the one opportunity you have to advocate for yourself, because you know your disease better than anybody else, and it's going to be that way always. if you've got the opportunity to have a short and quick summary of what's wrong with you, or your child, or your mother, or your sister, or whatever, a little summary, you can get it from the doctor, you can get it from the brochures that the pharmaceutical companies or the disease publishers write. Have something there, have a list of your medications, have kind of a vial of life or something that keeps your summary of what goes on. People in the emergency rooms, I can't tell you how many times my patients will say, I went into the emergency room, I sat there, they have no idea what's wrong with me. And I'm like, I know, but there's 7,000 rare diseases. If you had a heart attack, they'd know what to do. Or if you had COPD, or if you had diabetes, or if you broke your leg. Yeah, but that's a big burden to put on somebody else. They are so grateful when they have somebody who comes in the door and is kind enough to say to them, I need you to know I have this. Here's a little summary of what it is, and this is why I'm telling you. You're always going to be the smarter one. Always, unless you're seeing your specialist or somebody who's just really lucky and has been to a meeting about something. So websites, I'm a website girl. The most commonly used online Medicare resources are Medicare.gov and CMS.gov. The Medicaid resources, Medicaid.gov follows, right? CMS.gov. Those websites used to be a nightmare. They have become so much better in the last few months. I really, if you're involved with Medicare or Medicaid, I would really suggest you go there. They're pretty easy to navigate. I spent a long time on the websites last week in preparation for this. I was pretty impressed. Our government did something right. So here's some other little hints. Just a few little websites. How to choose from affordable healthcare options. There's a healthcare.gov, and it talks about comparing plans. That's kind of a cute little summary thing that they have. Consumer Reports also has a little article that they did on how to pick a health insurance plan that I read, and I'm not endorsing necessarily any of them, but they are there for your reading, and they're actually pretty good. NORD has a website with a whole section on state health insurance information. It breaks down all the Medicaid plans, because although Medicaid is a joint federal state funded option, they basically are all different in every state. Medicare, good all across the country, same everything. Medicaid, based out of your state. And if you ever had questions about Medicare versus a Medicare Advantage plan, which is really, it's Medicare Advantage plan, covers your Medicare A and B and your D. There's a MedicareAdvocacy.org, and it will tell you about choosing between the two different kinds. A Medicare Advantage plan, it's like managed Medicare, it's what I did at Aetna actually. They have to offer everything that Medicare offers, everything. But they can also offer some other things too, like home infusion, which in my avenue of career, that's really important. Also, you've got some rare patient assistance program examples, NORD, PSI, the Rare Disease United Foundation, the PAN Foundation. PPARX, that's a cool website. If you're on prescription medications that are brand and you wonder if there's a way that you qualify for assistance, my dad's on Crestor, and they're on a very limited income. And so he actually went to the website and he qualified for the insurance. So instead of now paying his $364 copay for his 3 months, he pays nothing. He got it. And I'm his favorite daughter. So I know this was really fast, but hopefully, if you looked like this at the beginning, I maybe have inspired you a little bit to not be afraid. And don't be afraid to call those insurance companies and ask them questions. So if you do, by the time you're done, your ride will look more like this. Thank you so much for your time.
We have time for a few questions.
Hello.
Hello.
How are you?
I'm fine. How are you?
I'm wonderful.
her.
So I wanted to know, where can we find your slide deck?
Excuse me?
Where can we find your slide deck? All the valuable information you provided
So, Robert,
us.
do you know where they can find my slide deck?
I think Global Genes has access to that.
Yeah, I think Global Genes is going to have access to it, and there's a couple different things that I included with the deck. The spreadsheet for comparing your insurance. Ooh. The spreadsheet for comparing your insurance is going to be with it. The description of what different kinds of plans mean, HMO, PPO, POS, LMNOP, QRS. It gets crazy, doesn't it?
Thank you.
So, yeah, that's where it'll be.
Question is more for Marie. Can you speak to the concept of a pre-certification from the insurance?
Sure. Effectively, the pre-certification can sometimes be treated like a benefit consult with the insurance company. However, a pre-cert typically can behave in the same manner as a prior authorization. That's theoretically what should happen, although I would suggest both the specialty pharmacy have a conversation with the insurance company, and the patient should talk to that insurance case manager to make sure the insurance company or health plan is actually treating it appropriately, because each plan is going to handle it very differently.
Okay, I have actually experienced where the pre-certification is more of a gentleman's agreement, but it's nothing in stone. And I'm not sure what's going on between the insurance companies and the providers, but we had a pretty substantial piece of equipment dispensed to us, and the provider was asking us to sign a paper that basically waived our rights if the insurance chose not to pay for
Really?
it. And
Oh, that's
the
not good.
insurance supposedly gave a pre-certification which said, sorry, this doesn't have to be authorized, no big deal, but this was a $100,000 wheelchair. So
Yeah.
I didn't sign the paperwork. The
Yeah.
provider still dispensed the equipment to us, but that provider is now on the hook for a substantial amount of money, assuming the insurance decided not to pay that claim. So
Right.
I was just curious if you had any knowledge on
I think
that and the legality.
it
and-
depends on the insurance company, to be honest
Okay.
with you, but hitting up that case manager at your insurance plan is the way to go.
Yeah, I've been unsuccessful there, but anyway,
So, like, do you have commercial insurance?
yes.
So there is a case
there
manager.
is.
They have somebody assigned to you.
I have that case
But they're not
manager,
helpful?
and they're not very helpful with
Have
it.
you taken it up?
So,
I have to be careful. I have to be careful how I speak about it, but
All right, maybe we can catch
Yeah.
up after. Yeah, go ahead.
So just having done that in one of my 4,000 cat lives, if that case manager is not helpful, you can get a different one. There's a bunch of them. I mean, you can get a different one.
we've had good case managers in the past. There's a unique situation, part of the reason why I can't really talk about it.
Okay.
It's
Okay.
I'll chat with you off.
Okay.
So the thing about the pre-authorization, that one of the important things is that you just brought up that I probably didn't emphasize, get a pre-authorization number. If you're on a treatment and they say they got pre-auth for you, we got pre-authorization for your medication. So one of the things I tell my patients, if we know your pre-authorization has this number, I give, they ask me for, they'll give me the number and I'll tell them, I said, okay, now, when is it good for? Is it good for 6 months? Is it good for 12 months? Is it good for 2 years? Get the dates. Hang on to the dates in your calendar. Like, I live by my Outlook calendar. 6 weeks before that that pre-cert is due, I put a tickler file in there and I say, call Dr. So-and-so and ask him if the recertification has been started. Because like you said, it can take weeks.
Yep.
But you don't want to get there. Say if you're on an infusion of some kind, you don't want to get there and have him say, oh, you know what? We're sorry. We forgot to do the pre-auth. We forgot. So you can't get your treatment today. So that's part of the teaching to fish thing. I tell my people, here's what you do. You put that in your calendar, and I'm going to put it in my calendar. But when you go, because you're going to see the doctor, I do it telephonically. You're going to see the doctor when you go in this treatment. You're going to need treatment, 2 more, 3 more before this whole thing is up. Start them now. And you'd be surprised, they're very grateful. They're like, oh, we forgot, because they don't have a tickler, but we do.
And sometimes the prior auth isn't just time-bound. Sometimes the prior auth is a fixed amount. If it's an infusion, it's X number of vials, or it could be X number of pills. So you want to actually know time and amount.
Yeah, and they'll issue it one way or another. It's usually not both, but it's usually one way or another. They'll say, 26 doses. If it's every 2 weeks, they'll give you for a year. But they'll do it by doses.
wondering if you have any tips for me. How do you get an HMO to pay for a specialist that you really need out of plan? And so I have a rare cancer, and we're actually told go to a specialist center, sarcoma center, and that is how we get the best care. But if you're stuck in an HMO, they won't pay for it.
So you will have, and I to go back to toot my case manager horn, but there's got to be somebody at that insurance company who knows about your case. And I have found, maybe not all the time, like the experiences that you've had with case managers, because believe me, there's ones out there that are not as good. But I would encourage your doctor. They can do an exception. There is a possibility of doing an exception, but it has to come from within the insurance company. And the doctor has to be very proactive in making sure he writes a letter. And you talk to the case manager, and you do ask for special consideration, and it's been done. Good luck.
Time for one more question.
So I have been trying to get a case manager assigned for the past year and a half, and I keep being told they don't do that. And everybody that I know who has children with rare diseases or complex cases keeps telling me I need a case manager. And I have gone round and round and round. I have talked to one person after another, and they transfer me to somebody else, and they just keep telling me it doesn't exist, we don't have anything like that, you're on your own, basically. Are there some insurance companies that just really have nobody out there, or we're going to a hospital that's not in network.
Okay.
My daughter has very expensive treatments every 2 weeks. They're spending a lot of money, and I just keep expecting them to drop us, and they just keep getting increasingly difficult to deal with. And I don't know if it's me or if I just kind of feel like they'll make things as difficult as possible until you just drop it and give up.
Is it regular commercial insurance that you have?
It is.
Maybe we can talk offline, and I can
Okay.
kind of,
Okay,
I don't
thank
want to
you.
humiliate an insurance company in public.
Thank you.
All right. Everybody give a big hand to our presenters here.